Yep, I can.
Excellent. So thank you for joining us today. This is our Learning Health Systems seminar series hosted by Accords at the University of Colorado Anschutz Medical Campus. So what is Accords? Accords conducts pragmatic research in real-world settings to improve healthcare and outcomes by providing a lot of really amazing services. And specifically, you're here with our education program, which provides extensive educational offerings both here in the Denver area and nationally. We have recently also become an official campus center, so be on the lookout for new branding and information about Accords in the near future. Accords is supported by both the University of Colorado School of Medicine and Children's Hospital Colorado, and is really a unique one-stop shop environment for faculty to conduct pragmatic research, receive various services and supports for grants and projects, incredible mentorship, training, and education in health services research. Some other upcoming events. So later this week, you'll see as part of our qualitative and mixed methods research mini-series, using theory for designing mixed methods studies, presented by Kate Coleman-Minahan. And in March, we have a number of upcoming events as part of this series, the Learning Health System Seminar. You'll see the Empowering Embedded Pragmatic RCTs in the Vanderbilt Learning Health System, actually at University of Michigan. That's a mistake, sorry about that, from Gretchen Piat. So we're really excited to welcome her next month. And then in March, as part of our qualitative and mixed methods research mini-series, you'll see leveraging technology to collect qualitative and mixed methods data in asynchronous and remote settings, presented by our own Sheena Bull. Later in March, we also have our Community Engagement Forum, co-hosted with the Community Engagement Core at Colorado Clinical and Translational Sciences Institute. And save the date or get registered now for CopperCon in May. So that's scheduled for May 23rd, 24th, and 25th. Today, we have Dr. Charlesnika Evans presenting for us the Veterans Health Administration Quality Enhancement Research Initiative Model, specifically using rapid response teams to inform a national COVID-19 vaccination program. Dr. Evans is an epidemiologist and research career scientist with the Department of Veterans Affairs Center of Innovation for Complex Chronic Health Care at the Edward Hines Jr. VA Hospital in Hines, Illinois. She's also a professor in the Department of Preventive Medicine and the Center for Health Services and Outcomes Research at Northwestern University in Chicago, Illinois. Dr. Evans is a principal investigator at the VA Quality Enhancement Research Initiative Program, focused on rapid implementation of evidence-based practice to prevent the spread of antimicrobial resistance. She also leads and collaborates with other scientists on several other research grants funded by VA, CDC, and NIH, mostly focused on infection prevention and management. So join me, please, in giving a warm welcome for Charlesnika Evans as she gives our seminar today. Charlesnika, you should be able to go ahead and share your slides now and take over.
Great, thank you. Excellent. So thank you for that warm welcome. And also I want to thank Accords and the University of Colorado for inviting me to do this talk. Very happy to talk about the work that we're doing with the Quality Enhancement Research Initiative, or QUERY, and to specifically discuss the model that we're using, as well as the introduction of rapid response teams. That is a new component of this QUERY model that we use to inform a national COVID-19 vaccination program. So first, I want to express a disclaimer that this presentation are my views and do not necessarily reflect the position or policy of the Department of Veterans Affairs or the U.S. government, and that I have no conflicts that relate to this presentation. So first, I want to orient you to the learning objectives, which will be to describe the Quality Enhancement Research Initiative model for implementing evidence-based practice, discuss the purpose of rapid response teams in the context of the query model, and then describe the use of rapid response teams in informing a COVID-19 vaccination program. So I want to first set the context for VA as a learning health system and how research is embedded in the system through the query program initiative. Then move on into providing an overview of the rapid response teams as one example of a new model of embedding researchers to rapidly respond to the needs of clinical operations. And then finally talk about our work that we did as a rapid response team to address the VA's rollout of the COVID-19 vaccination program. So for those of you who are not familiar with Veterans Health Administration, or VHA, it is the largest integrated healthcare system in the United States, and it's part of the Department of Veterans Affairs. And you'll hear me use VA and VHA interchangeably throughout this presentation. VHA serves 9 million US military veterans across all 50 states and territories. And this care is provided through 171 medical centers, over 1,000 outpatient clinics, and by over 320,000 employees. VA also has a large intramural research program with a nearly $800 million congressional appropriation for medical and prosthetic research. And that was in fiscal year 2021. And a combined research budget, including both VA and non-VA funding of over $2 billion. So because VA is an intramural program, the presence of research spanning the continuum from basic science to health services research to translational and implementation research has helped the VA become really a premier learning healthcare organization and learning healthcare system, and has really contributed to the significant improvements in quality of care that we've seen in veterans over the past 2 decades. And I know as part of the seminar series on the learning health systems that you've had several presentations about what a learning health system is and seen examples of them. So I just want to outline briefly how VA is a learning health system based on the Institute of Medicine's core elements of what a learning healthcare system is. And these include the use of the VA's electronic health record that provides real-time access to patient information, guidelines, electronic clinical reminders, as well as alerts. Also, the VA digitally captures care through its corporate data warehouse and conducts patient surveys to get at veteran or patient experience. The VA MyHealthyVet patient portal is a personal health record tool that has been used to empower patients, allowing email communication with their healthcare team, access to their medical records, including clinician notes, and educational information. Now you'll hear a little bit more about the MyHealthyVet group as we use these users to understand COVID-19 vaccination perceptions. Other areas that support VA as a learning health system include alignment of value with incentives. For example, having salary clinicians removes incentives based on volume of care. VA is also a public agency that publicly reports large volumes of data on quality. Clinicians also have access to multiple clinical dashboards, which allow them to track quality relative to peers. And independent researchers publish widely on the quality of VA care. And in fact, a strong culture of learning is supported by the strong academic affiliations in larger VA medical centers. In fact, numerous clinicians and non-clinicians have dual appointments between VA and its academic affiliates. I'm an example of one of those people. And then strong training programs across multiple disciplines. And then finally, there's an emphasis on system redesign and lean training, but also there's a strong focus on implementation science. And that is really where the VA's Quality Enhancement Research Initiative, or query, comes into play. So as an integrated healthcare system, the VA has really been in a unique position to translate research findings into clinical practice to improve the healthcare provided to veterans across the United States. The Quality Enhancement Research Initiative, or query, is an initiative part of the research enterprise of VA, which has facilitated this opportunity for translation and implementation. Query specifically links VA research and clinical operations to ensure veterans have access to leading-edge, scientifically supported treatments and care. And since 1998, or for more than 20 years, Query has been committed to improving the health of veterans and their families by accelerating the adoption of evidence-based practices or research findings into routine clinical practice and healthcare policy using implementation science methods. So I want to introduce you to the query framework or the implementation roadmap that is used to orient researchers as well as clinicians and clinical partners to query in the work that we do. Query has evolved the learning health system framework to address the need to go beyond traditional quality improvement methods and to use implementation science methods to support stakeholders in systematically planning, deploying, and sustaining evidence-based practice in routine healthcare settings. The query implementation roadmap here provides really practical guidance for healthcare practitioners and researchers to plan and deploy methods to support uptake of effective practices in routine care settings. It includes 3 phases and is an iterative cycle of continuous improvement. So in the pre-implementation phase, healthcare leaders or other stakeholders identify priorities and commitments to apply evidence-based practices to address these priorities. In the implementation phase, knowledge is put into action by using implementation strategies to support the spread of evidence-based practices. And then in the sustainment phase, the impact of uptake of the evidence-based practice is evaluated in terms of benefit to veterans and other stakeholders. And then steps are taken to ensure that the evidence-based practice can be sustained by leadership and operations partners. So this roadmap is really essential to any learning healthcare organization because without planning for implementation at all levels of the health system, it can really take years to have impact on improving the use of healthcare practices and making sure that they reach patients who need them the most. So I wanted to orient you to the overall structure of Query. Query has multiple centers and initiatives within it, but the one I really will focus on today are the Query programs. And these are the entities that develop and implement strategies to support uptake of evidence-based practices. So one of these query programs is the Combating Antimicrobial Resistance through Rapid Implementation of Available Guidelines and Evidence, or CARAGE. I know that's a mouthful. I co-lead this query program with Mike Rubin from the Salt Lake City VA and the University of Utah, Eli Perensevich at the Iowa City VA and the University of Iowa. And with our recent renewal of this program, we have one additional PI, Makoto Jones, who's also at the Salt Lake City VA and University of Utah. The goal of the CARAGE Query Program is to really address the public health crisis of antimicrobial resistance and other emerging infectious threats. And we do this through strategies that support the uptake of new and existing evidence-based practices. And we specifically target improving use of antibiotics, biosurveillance, and the prevention of the spread of these infections. And we currently have 3 projects that we're working on now with our new query program. One is focused on implementing strategies to improve terminal room disinfection through UVC devices. Another is implementing a national tracking tool to rapidly identify patients with high priority resistant pathogens admitted to the hospital. And then our third project is improving antimicrobial use through audit and feedback strategies. This image here is just to show you the breadth of programs across Query that Query CARAGE, which we are here, is just one of 14 query programs funded across the country to address cross-cutting, high priority issues for VA with implementation science. Now, query programs have always focused on identifying implementation strategies to improve the uptake of effective practices. And these implementation strategies could be anywhere from education and training to audit and feedback to facilitation, a number of different strategies that are being used. And then we're also using data-driven methods to evaluate the impact of these programs. Again, the VA has a large electronic medical record and a large corporate data warehouse that's seeded with all of that information from the health record. But most recently, another component was added to the query programs, which is the rapid response team. So rapid response teams are groups of embedded researchers collaborating with VA clinical and policy partners to facilitate a particular goal. And they were introduced to rapidly respond to immediate time-sensitive needs of clinical and operation partners. This was seen as a hole that was missing in query, and so the rapid response teams were added to really address this issue of needing rapid, immediate evaluations or implementation projects done in a quick fashion. Query program rapid response teams are comprised of query-funded investigators who work on time-sensitive, generally 3 to 6 month evaluation or implementation projects. They're requested by a VA program office or a VISN or regional leader and are aligned with veteran healthcare priority goals. Rapid response teams work on retainer and are expected to include team members with expertise as clinicians, mixed methods, including qualitative and quantitative expertise, and quantitative data analysis expertise, particularly with knowing how to use the VA's corporate data warehouses. Rapid response team requests can come directly from VA operation partners, again, those program offices or regional directors, or from query programs where query programs can submit those rapid response requests on the behalf of a national or VISN operation partner, as long as they provide supporting documentation that the partner's interest in the topic. These rapid response teams then operate under a memorandum of understanding with the requester before beginning the project. That includes the objectives of the rapid response project, a list of deliverables, expectations regarding resources and communication, and a timeline. And I'm sure one of the questions you might have is, do you get extra money for this? So in general, the query programs are supposed to build this into their budgets already, but depending on the question and the needs, additional funds are provided. And at least for these rapid response teams that were deployed for COVID-19 vaccine, they did provide additional funding to us to do this work. So we know that the COVID-19 pandemic brought systems to their knees, and really the VA was no different, with an urgent need to think about developing and implementing plans to vaccinate veterans and employees against COVID-19 in 2020. So these rapid response teams that were deployed, the first ones were on about COVID-19 vaccine. And what happened was, in November of 2020, a request was issued by the Query Central Office on behalf of the VA's National Center for Health Promotion and Disease Prevention. This is the program in VA that oversees education and training, education of patients, training of healthcare employees related to areas of health promotion and disease prevention. And particularly, they were over the large educational campaign for making sure that veterans and employees were aware of COVID-19 vaccine. Query programs who were interested were allowed to respond, and 3 were selected to have rapid response teams. So again, 3 rapid response teams were deployed to conduct small-scale studies to establish a baseline assessment of attitudes, intentions, and beliefs of veterans and employees regarding COVID-19 vaccines and evaluate vaccine messaging. Knowledge gained from these rapid response teams was basically used to promptly assist VA partners in identifying key targets for improving vaccine acceptance, improving training and communication strategies, and identifying future research related to promotion of COVID-19 vaccines. These rapid response teams were part of 3 different query programs. So again, the Carriage query, which I co-lead, the Bridge query, and then the Function query. And I'll talk about what we did as a whole, but only presents a few of the findings from the Carriage query and what we did. So this is just to give you a picture of the types of questions we were trying to answer on behalf of the National Center for Health Promotion and Disease Prevention. Each team had a set of questions they were to answer. All of our data collection tools, we really work together in developing and sharing information, sharing questions across our groups during the first few weeks of development of the projects. We, as what we call us ourselves, they called us RRT3, or Rapid Response Team 3, because there was 3 of us. And we met together on a weekly basis, again, sharing information, sharing questionnaires, ensuring complementary but different samples of veterans, employees, in order to make sure we had a larger breadth and cross-section of veterans and employees that we evaluated across the country. And as you can see here, we used a number of different methods, from surveys to focus groups and interviews, for both veterans as well as employees. So, you know, what we did, you know, conducting these surveys, interviews, and focus groups, the direct response to our partner NCP, or National Center for Health Promotion and Disease Prevention, you know, the information we provided to them, you know, was not complicated. Really what we did was we provided updates and preliminary findings on a bi-weekly basis to them. We had a shared SharePoint site where all of our reports were uploaded so that NCP, the Query Central Office, as well as VA Central Office as a whole, could look and look at what we have been posting, what type of findings we were identifying. You know, as for example, surveys came in, we were processing those and updating the findings again, like on a bi-weekly basis. In these reports and updates, we tried to focus on findings such that might be more actionable for tailoring communication strategies, such as reasons for not getting a COVID-19 vaccine. Each group refined strategies and procedures based on stakeholder feedback. For example, as the next available vaccine from J&J became available, we were asked to revise some of the language in one of our surveys to address understanding willingness to obtain this vaccine. This was, of course, a rapidly moving target in terms of the science and what we knew was happening at the time we were trying to develop and deploy the surveys and other data collection tools that we were using. We also participated on the VA's vaccine education work group, which again was a group responsible for the education, training, and communication strategy for COVID-19 vaccine. And lo and behold, this group was led by the National Center for Health Promotion and Disease Prevention. So not only were we providing these bi-weekly reports to them, but we were also participating on these weekly meetings as well. So not only were we giving updates on what we were finding, but then they were providing information as well on education materials that they were developing for veterans as well as employees, that then we could provide feedback on based off of what we were finding in the surveys and other data collection methods that we were using. We also learned about the current state of COVID-19 vaccination rollout in the VA as well. And as we learned about that, we were able to incorporate that into our methods and findings as well. So as I said, there was 3 rapid response teams deployed, but I'll specifically give some details about the work we did as part of the rapid response team for carriage query. We conducted a 6-month rapid response quality improvement project to support NCP with the goal of assessing veteran COVID-19 vaccine intentions and receipt, and inform NCP on ongoing efforts to increase vaccine uptake across the VA healthcare system. We conducted 3 surveys. One was an online survey of the 4C survey of MyHealthy visitors. And if you're familiar with the VA, you may know about the 4C survey, which is a monthly patient satisfaction survey of MyHealthyVet users. And remember, MyHealthyVet users are those veterans who use their personal health record to communicate with their care team, use it to look at their medical record, etc. And we were able to leverage this resource by collaborating with the MyHealthyVet office to add 5 questions about vaccination intentions and beliefs. This also coincided with the interest in learning more about their particular users and vaccine intentions. So MyHealthyVet office was very interested in collaborating with us in order to do this. Now, we initially hoped that this would be a quick way of getting some really quick information about veteran perceptions about the vaccine. But it turns out that there was a lot of bureaucracy that we had to go through to add those 5 questions. So well, we thought that this survey would go out no later than February of 2021. It did not go out until May. We also conducted 2 cross-sectional paper surveys of veterans in facilities with low vaccination rates. And I won't go into the details of all the numbers of facilities that we looked at, et cetera, but we fielded the first survey in March of 2021, and then the second one in May of 2021. So for the MyHealthyVet 4C survey, so I'm going to just give you a little overview of some of the findings from these 3 surveys. With the MyHealthyVet 4C survey, we had a very high response rate. Again, these are users of their personal health record. This survey was sent to 10,000 MyHealthyVet users, and we got a response from over 7,800 of those users. We added again, 5 questions to their usual survey related to COVID-19 vaccination intentions or status, reasons for getting the vaccine, reasons for not wanting to get the vaccine, their perceptions about COVID-19 vaccine safety, and then trusted sources of information about COVID-19. And you'll see these images on the next 2 to 3 slides. They come from one of the infographics that our group made on behalf of the MyHealthyVet office to present some of the findings. So I thought it would be nice to just show pieces of those infographics that were used to communicate some of the findings that we identified from this survey. But as you can see here, there was a very high number of MyHealthyVet users who had already received the COVID-19 vaccine. 4 out of 5 had already received the vaccine by the time of May 2021. MyHealthyVet users who received the COVID-19 vaccine were more often male, white, and older than those who had not received the vaccine. We also looked at specifically further those who were unvaccinated and looked to see if they were likely or very likely to get the vaccine, which we called a favorable vaccine, being favorable towards the vaccine, or being unfavorable, meaning that they definitely would not or probably would not get the vaccine. And we didn't see any differences in gender in this group in favorability of willingness to get the vaccine, but we did see that younger groups tended to be a little less favorable about the vaccine than older age groups. We also saw significant differences in race and ethnicity by likeliness to get the vaccine as well. And again, these are just in the group that were unvaccinated. Then we also looked at beliefs among those who were unfavorable about getting the vaccine. And some of the reasons for not wanting to get the vaccine included thinking that it was unsafe. They didn't think it would work well. They thought that they would not get COVID-19 or even get very sick from it. And that they thought that the COVID-19 outbreak was not as bad as some say. So I said we did 3 surveys. The other 2 surveys were paper surveys, and this is just an overview of sort of our methods and our sample selection criteria that we used, which got a little complicated. But really we were focused on users of VA, so they had to have been seen within the VA in the past 2 years at one of the facilities that we had identified had low vaccination rates. They couldn't have been in long-term care. Again, we were really looking outside of the long-term care group and really trying to understand people who were living in the community. They needed to have a complete mailing address for us to send them the survey and complete data on race and ethnicity, because we wanted to make sure that we had a good number of people in each strata that we looked at in terms of by race ethnicity for wave 1. And then for our second survey that we did, we wanted to make sure we also had an adequate number of women in the sample, as well. As we learned from the first one. Again, we know that the VA is primarily cares for military veterans who are male or men, and we wanted to make sure to get an adequate number of women in that second survey that we did. So briefly, you can see here that in our first survey that we conducted, the number of veterans who had received the vaccine was 60%. And by the second wave of the time we did this second survey, it was 80%. So we saw an increase in COVID-19 vaccination between March and May, which you would hopefully expect. One of the other things we looked at, we had a number of questions, but just to show you some of the reasons behind veterans who received the vaccine versus those who would not get the vaccine and their perceptions about believing vaccines were unsafe. So those veterans who received the vaccine were more likely, those who did not receive the vaccine were more likely to believe COVID-19 vaccines were unsafe and ineffective. They were more likely to have negative attitudes towards vaccines in general. Less likely to trust science experts like Dr. Fauci. And then we also noticed that in our second survey, wave 2, respondents were additionally less likely to trust their doctor. So thinking that by the time we get to this next wave of people who had not been vaccinated, we're really getting the people who are really entrenched in not wanting to get vaccinated at this point. Just a summary of some of these brief findings. We continue to work on analyzing some of this data. Again, the rapid response teams were made to provide quick information to the program offices. But of course, as researchers, we also want to publish what we find as well. And so we currently have one paper under review and then another in development on the changes over time that occurred. But overall, we saw vaccine uptake increase. We identified roles of perceived vaccine efficacy and safety, perceived risk of COVID-19 versus getting vaccinated, and trust in medical experts in COVID-19 vaccination uptake. And these findings are consistent with what has previously been found on vaccine intentions, particularly around COVID-19. So some lessons learned that we really had some concerns and issues with during deploying our rapid response teams were really recognizing that we needed to use methods that were fast and flexible. we know that, doing the paper surveys were difficult to deploy quickly. You had to put together the surveys, label everything, get it out, then process all those that were coming back in, send a reminder, send another survey to those who hadn't responded. So that took a lot of staff and time in order to do that. So future rapid response projects and rapid response teams to think about methodologies that they use to that could be more fast and more flexible for the purposes of answering the question. And so one way to do that is to take advantage of existing evaluation opportunities and infrastructure. We did that by using MyHealthyVet. They were already doing their monthly surveys, and adding the 5 questions seemed like a no-brainer and that it would be very quick. It turned out not to be very quick, but we think that for future activities, if someone wanted to use that, I think we've worked out the kinks in terms of being able to rapidly move that forward than what we experienced for this particular rapid response project and team. And then managing expectations and developing realistic plans. Again, we did 3 surveys. I didn't know here, but we also did focus groups as well. And that was a lot for a 6-month quality improvement project. And so, we will take this into account when thinking about what's realistic for the time frame that we have with the staff and time that we have available to us. This is the landing page for learning about COVID-19 vaccination for VA, which evolves over time as this work took place. So, we provided a lot of feedback and input to the educational materials and plans that NCP had for rolling out the COVID-19 vaccine and continuously updating their materials and training materials for employees. So we believe that the work that we did had a direct impact on the information that they were providing to veterans and employees. Finally, I wanted to acknowledge everyone who was engaged in some way in this project. First, the funding for this was provided through the query programs. As I said before, the rapid response team started at the end of our old query program and the start of our new. The other carriage query PIs noted here before, and also specifically the rapid response team engaged in this. A lot of people provided a lot of input from the Hines VA as part of the rapid response team, Salt Lake City, as well as Iowa City. And then I also wanted to acknowledge my co-collaborators within the query rapid response teams, or RRT3. Those leads were Ronnie Elway and Nina Sperber. We could not have done any of this without working together as 3 teams rather than as just one individual team. And then also our operations and clinical partners, our main points of contact with NCP and the Vaccine Education Work Group, as well as the MyHealthyVet office and the company that they use to analyze their patient satisfaction data. And if you want to learn more about Query's model and the work that Query does, these are just a few of the references that you can take a look at from David Atkins and Amy Kilborn on Query and the work that has been done over the last 20 years. And finally, just to note, these are my email addresses and my Twitter handle, so please feel free to contact me if you have questions and want to know more about the work that we're doing. Thank you. I'll open it up for questions.
Thank you so much, Charlesnika. It was a great summary of this approach that you've taken for addressing COVID-19 vaccination. We've had a couple of questions come up in the chat and some others that our team had talked about before bringing you in. One of the questions is about the funding and whether the funding for the example projects you shared here were really coming from the query program, But what other sources of funding have you been able to use to do these sort of rapid response or implementation studies in the query setting?
Yeah, so one of the challenges with doing the rapid response teams are that you need to have the staff available. And so generally, we all know we work in a soft money environment. So all people need to be funded in order to keep them on board. And so for us, we had to look at who do we have available in terms of staff to do some of the logistical work, right? And their, kind of uncovered time that we would say was really provided through our Health Services Research Center, which is, where all of our projects sit under. So besides that, we really worked with the Query program, Query Central Office to get additional funds to be able to cover the time of those individuals, as well as see if we could get additional people involved. Generally for us in the VA, we rarely have to pay for like postage and things like that. So the actual deploying of the survey, I mean, we pay for supplies and everything, but it's not a huge cost for us. It's really the personnel and making sure we had the people available for that.
Great. Another question that came up is really about digging more into the MyHealthyVet platform that you have access to. I'm hoping you can talk a little bit more about that platform, who is engaged in and signed up for that. So like what percentage of your vets are participating in that platform? How do you maintain engagement over time to get such great response rates that you described? And maybe how that fits into the sort of larger learning health system environment of the VA.
Yeah, so I don't know what percent of our vets are on MyHealthyVet, but I do know that that program office that oversees MyHealthyVet is very engaged with the veterans who are signed up for it. They do a lot of work in advertising for veterans to sign up for MyHealthyVet, getting them registered. They can come to a VA facility that will help them register for it. So there's a lot of resources put into getting veterans engaged in MyHealthyVet. And so from what I understand, they are a very engaged group of veterans, which, goes to generalizability, right? In terms of at least this cross-sectional survey that we did, that group of people may be very different from the MyHealthyVet users that we surveyed. So yes, a very engaged group. The fact that they're using a personal health record and using it, on a consistent basis. This is how they end up getting a survey, because they've used the MyHealthyVet recently, and these go out every month.
Great. Can you the last part of that, can you talk a little bit about how either Query uses that MyHealthyVet platform for other learning health initiatives and implementation of those evidence-based practices across the VA?
There are groups that are engaged with implementation of the personal health record and using it as a tool to provide information to veterans. I know that one particular researcher, Timothy Hogan, who's part of the Bedford VA, but who sits in the Dallas VA, I think, does a lot of work around personal health records and working with the MyHealthyVet office in their work. This was a example of how we could use MyHealthyVet for the purposes of, getting these questions added to their survey. This is not something that they routinely do. It was something that we went to them with, and they thought, yeah, this is great, because we actually want to know what our veterans are thinking, our users are thinking about vaccination. So this actually coincided with a goal that they had as well. And so we worked on the questions, got input from them. They told us, we originally had, 10, 15 questions, and they said, we can only do 5. So, so I think it worked out nicely to be able to work with them and use the infrastructure that they already had to do this, but it isn't something that they necessarily do on a routine basis.
Great. One of the conversations that we have been having with some of our colleagues here in Colorado, it's been about the balance between sort of speed and rigor in these kinds of studies. And you talked a little bit about it, but would you go into a little bit more about how your team approached that potential tension, some of the challenges maybe, and advice for others in trying to balance doing things quickly and doing things really well and generalizably, as you pointed out?
Yeah, I'm going to say stay simple. I mean, we came up with, we go back to that one slide that had the wave 1 and 2 surveys and the stratified random sampling. We rightfully so wanted to make sure we had adequate sample size for our race and ethnic groups to make sure we could answer questions about them. Those were a priority. But in trying to analyzing the data, making sure we actually got, the sample size we expected from them, it just got to be a lot more complicated. And so I would say keep it simple, keep it realistic in terms of what you plan to do. We truly, looking back on it, trying to do the 3 surveys plus the focus groups it was very challenging to complete all of that within 6 months. So I think, just keeping a good mind to focusing on maybe one thing and doing it really well.
What other questions do people have for Dr. Evans? We have a little bit smaller group today, so if people want to jump in with some questions, we have a few more minutes. Amy, do you want to just unmute yourself and go ahead and
Oh, I see the message from Amy. I'm actually looking at the chat now. So the question is, or comment in question is, I noticed that the VA landing page about COVID-19 had messages about vaccination from both clinicians and from fellow veterans. Did any of the messaging for veterans come out of this RRT work? I would hope so. I would hope so, particularly with the bridge query, which was the other query program led by Ronnie Elway, the other rapid response team led by Ronnie Elway. They did a lot of work around messaging. So that was their major contribution to this effort. Not only did they do focus groups and I believe interviews and did some surveys, but their expertise is in communication and messaging. And so they really worked directly with NCP in making sure the messaging was appropriate. So I believe that a lot of the messaging that you see and as it changed over time could be directly attributed to the work that they did.
Dr. Evans, it's Heather Gilmartin. I know you from the VA. I have a question. Do you anticipate publication being a challenge, considering it was this chaotic yet rigorous approach?
Yeah, so what generally, right, what we report and put together for our partners and these reports don't necessarily fit well for manuscripts. So we really had to rethink and reorganize the information that we collected and put it into a more reasonable manuscript form. So that's been a sort of a challenge with getting it published, because then we have to take all this information that we have and really put it into a form that is acceptable for publication. So we currently have one paper that's under review now based off of our first wave of data for the cross-sectional survey. And then we will probably be developing another one to look at changes over time for the 2 cross-sectional surveys of wave 1 and wave 2. I'm hoping it can be published, though. I think it can be. It's quality improvement, and we know quality improvement generally for the purposes of the project are to inform that particular project and not necessarily be generalizable for the larger research community. But I think that is one of the ways that query is unique, in that we are able to take that information that was specifically developed to address a specific purpose within VA or for a particular partner, and show how it is important and generalizable to the larger public.
Thank you.
Anyone else? I'm trying to make sure I can see if anybody else has a hand up or a question to ask.
I mean, of course, I have another question. Sorry. So I love that you guys used MyHealthyVet. Love it. And do you think there's Apple and all these other are coming out with health apps? Are the things that you've been able to do translatable over to industry? So for those not in the VA, who, is there a way for us to partner with these groups to collect data?
You mean through the MyHealthyVet, or just in general?
Through like MyHealthyVet type applications. I mean, they seem to be tons out there. What do you think?
I mean, it's so I think about, MyHealthyVet is a personal health record. I actually haven't seen all the tools that it has when I think about my own personal health record through the university healthcare system that I use. And I do think that it's an opportunity for collecting information from patients about what's going on in their lives and care. I must say that I have never, and I've been part of 2 large healthcare systems and had a personal health record there, and have never been, I don't think I've ever seen a survey or anything about something specific related to a condition or a broader question. So that seems reasonable to me, to be able to use those types of systems to ask questions, collect data that could really help with improving care in the long run.
Interesting. All right. Well, thank you. Thank you.
Charlesnika, what else have you learned about sort of maintaining these rapid response teams and having them available for future projects? You mentioned, we're in a soft money environment. We have to have people to be able to pull these off. Do you have advice or suggestions for your query team as a whole, or for others in learning health systems, about how to sort of develop that infrastructure and have it available for other rapid needs in the future?
Yeah, so I think you have to build in some cushion in the people that you have as part of your query program to be able to do this. And so there may be that, sometimes you've got like a 20%, 30% cushion of a project coordinator person who, and that's just one of the people that you need in order to make this work. And so as part of the query budget, you have them, put into that, because as part of the query programs, actually, it's required that we do 1 to 2 projects a year, 1 to 2 rapid response projects a year. So if you think about it in that way, that means that you should be allotting in your budget time for people in these to be on these teams. So really organizing your budget for a rapid response project, even though you don't know what you're going to do, but you may need to make sure as you're developing that budget for your query program that it includes, personnel for the rapid response project that you'll have to do during that year. It just so happened that we were in between ending the old query program and starting the new one, that they hadn't quite worked out the kinks of how this would all work. And so it was deemed that they needed to give us additional money in order to move this forward. But I don't think overall that unless the resources are of what's being asked is really a vast project, I think that it's really expected that you incorporate this into your query program budget for the future.
Great. Well, Charlesnika, thank you so much for joining us today. It's been a pleasure hearing about the work that you've done. And I just want to say a huge thank you on behalf of all of us who are here. If anybody has any last lingering questions, Charlesnika and I can stay on for a couple minutes. Otherwise, please take our evaluation. Tell us how you felt about today's seminar and join us for another one soon. Thank you so much.
Thank you, everyone.